I actually have a easier job than the prior speakers because we have a relatively new agent in the realm of inflammatory bowel disease, even though Ustekinumab has been around for almost a decade now for the treatment of another immune-mediated inflammatory diseases, which are psoriasis and psoriatic arthritis. Silvio attempted to show a complicated slide like this, and I think in distinction of how I think about IBD from cancer, cancer is pretty genetic and epigenetic. Inflammation needs to be more plastic and needs, as you've heard, changes and shifts in different phases of the disease because inflammation ultimately, physiologically, needs to result in resolution of the inflammation and shutting it down. And when it goes awry, we develop these immune-mediated diseases, Crohn's, ulcerative colitis, asthma, rheumatoid arthritis, psoriasis, psoriatic arthritis, multiple sclerosis, etc. It's intriguing, however, that the targets of this inflammation is different according to different organs. And similarly, we've learned a lot from rheumatoid arthritis and now psoriasis, and I think we have a lot more to learn, not just on the drugs that work similarly in these diseases, but there's a cadre of drugs that actually work differently. Some are beneficial, such as vedolizumab in IBD, and it's not likely to be tested in arthritis because the mechanism doesn't match. Some overlap, and some would appear to overlap, but they're still distinctive without specific benefits. We'll learn about that perhaps with other agents. So there are a lot of inflammatory players in here, and we've been targeting cytokines for 2 decades now since the development of infliximab and the targeting of tumor necrosis factor alpha. Interleukin-12 and interleukin-23, from my standpoint, are difficult to explain. They're mediators that are proximal to other mediators and actually inhibit the downstream signaling of both Th1, Th2 cells, Th17 cells, but also inhibit the production of tumor necrosis factor alpha. And yet there are going to be distinctions, as we'll point out in the side effect profile, between inhibiting IL23 and IL12 and inhibiting tumor necrosis factor alpha. So as a clinician, I have a difficulty in exactly explaining how this agent works. Interleukin-12 and interleukin-23 share a similar receptor known as the P40 receptor. If you inhibit P40, you're going to inhibit both IL-12 and IL-23. On the other hand, we have the potential, and there are a number of drugs in development that inhibit specifically IL-23 and do not inhibit IL-12. And from this diagram, it would be easy to understand that targeting the P19 receptor would be specific for IL-23. Now, despite the safety that we've seen in this co-inhibition of IL-12 and IL-23, there's some theoretical reasons why inhibiting IL-12 may not be desirable. These, I think, at the moment are theoretical, but it has led a number of companies to look at specific inhibition of interleukin-23. There are at least 4 or 5 monoclonal antibodies that are currently under development to inhibit IL-23, and we've seen phase 2 studies of these already presented, and phase 3 trials are now underway with several of these interleukin-23 inhibitors. But the inhibition of interleukin-12 and 23 together has now been studied for over the past decade. The monoclonal antibody, Ustekinumab, targets the IL-23 and IL-12 receptors via the P40 subunit, which is for both of those. So as I've already mentioned, there is co-inhibition of both of these factors when we target the P40 subunit. Ustekinumab is not a new drug. As I mentioned, it's been around for the past 8 years in the United States, approved for the treatment of psoriasis and psoriatic arthritis, and last year was approved for the treatment of moderate to severely active Crohn's disease for patients who have failed or were intolerant to treatment with immunomodulators or corticosteroids, but have never failed treatment with a TNF inhibitor, or patients who have failed biologic therapy with TNF inhibition. I very much share Silvio Danese's comments about the regulatory pathway, and for the past several years at this meeting, I focused on that this pathway has not changed in the past 20 years since the approval of infliximab in 1998, and in 2 months will be in 2018. So that will be 20 years into the biologic era, and yet the pathway has still been to look at patients with moderate to severely active disease not responding to A, B, and C. We'll see about these results, but I think ultimately looking earlier in the disease, as many of us have emphasized, will afford better opportunities. And where Brian says that he thinks vedolizumab should be a first-line drug for ulcerative colitis, I would state that in my observation, ustekinumab should be a first-line drug for treatment of Crohn's disease based on its safety and effectiveness, as we'll elucidate over the next few minutes. Bill Sanborn was supposed to give this talk. He's been a primary author of the studies looking at ustekinumab in Crohn's disease. And based on the phase 2 data looking at ustekinumab in Crohn's disease, and this is the data that was published now a number of years ago in Gastroenterology and subsequently in the New England Journal, we have moved the development forward into phase 3 and now beyond with ustekinumab. Similar to the pathway that we saw with infliximab and the other anti-TNF biologics, and even with vedolizumab for the treatment of ulcerative colitis and Crohn's disease, there were 2 inductive studies that both fed into a maintenance trial. Similar to vedolizumab, the 2 studies were divided into patients who were previously exposed to TNF inhibitors. That's the Unity 1 trial that I'll be describing. And the second trial was essentially patients who were biologic naive but had, quote, failed therapy with conventional agents, but still had moderate to severe symptoms when they were enrolled into the trial. Patients received an intravenous infusion of ustekinumab at 6 milligrams per kilogram, or at 3 milligrams, an infusion that was a fixed dose. And the patients who responded were randomized to receive ustekinumab 90 milligrams every 8 weeks or every 12 weeks in the study. Now, in the setting of psoriasis and psoriatic arthritis, the dose is 90 milligrams, followed by either 90 or 45 milligrams every 8 to 12 weeks. So we have, as we've seen with all of the other agents that we use in IBD compared to other indications such as psoriasis or rheumatoid arthritis, you can see that the dose has significantly increased. And it's not so difficult to explain when you consider the immunologic drive and the antigenic drive that's present within the gut, which is essentially a sewer, compared to the joints or even the skin. The drive is going to be greater. The induction studies included patients who had really refractory disease. And the only thing I want to point out on this this slide, is the highlighted disease duration, which was between 8 and 10 years of Crohn's disease, diagnosed Crohn's disease, before they entered into these trials. So if you recall the slide that we've been showing, and I'm sure you will see, of the progression of Crohn's disease through the years, by the time we get to 10 years of disease, a majority of patients are going to have transmural complications, such as some evidence of strictures or fistula within that. The Unity 1 trial on the left, and here we're looking at a clinical response, demonstrated significant improvement within the first 8 weeks of treatment compared to patients who were treated with, quote, placebo. And remember, the placebo in these trials are conventional agents, either steroids and or immunosuppressives. And the Unity 2 trial were patients who had never received a biologic agent, but may also have been on concomitant treatment with steroids and or immunosuppressives. As Brian demonstrated with vedolizumab, we see the same kind of effects with Ustekinumab. Indeed, we could show the same kind of results comparing a second TNF compared to a biologic-naive patient population, and we see a diminution of response in patients who were previously treated with biologic therapies compared to patients who were treatment-naive. There are two possible differences. One is that these patients did have longer disease duration and hence more subtle or not so subtle transmural complications, but these are also patients who have been refractory to one or more or multiple mechanisms of action for these agents. So similar to what we've seen with vedolizumab, the biologic naive patients did almost twice as well in absolute amounts compared to patients who were previously treated with TNF inhibitors, but there was still significant differences compared to the patients treated with placebo, because even with in the Unity 1 trial, the placebo-treated patients didn't do as well as they did in the TNF-naive population. And we see this across virtually all of the endpoints. This is the endpoints for clinical remission, significantly different compared to placebo by week 8. And we can also separate this into patients at the end of the year into patients who were treated with biologic therapy alone or with an immunosuppressive, as I will show you in a moment. Now, this is, again, a challenging slide to read, perhaps, but it looks at the pharmacokinetic and pharmacodynamic relationship that we've been learning about with the biologic therapies, including the tumor necrosis factor inhibitors, and as Brian Fagan has just shown us with vedolizumab. Again, looking at quartile analysis of drug levels at the trough, divided into the 4 different quartiles, we see differences in clinical remission rates, CRP normalization, and endoscopic responses and endoscopic remissions that appear to be higher in the patients who had higher concentrations compared to the lowest quartile of patients who had low serum concentrations at the end. I will point out that we still don't know the difference between the chicken and the egg, because when the mucosa heals, we retain more drug in the system and we're not losing it through the mucosa. So nevertheless, we do see these differences, and it is a challenge as we look into therapeutic drug monitoring as to whether the mucosal healing is driving the response or whether it is the drug concentration that's driving a response. And it may be a combination of both of these. Ustekinumab has been very safe. It's a first-line therapy for patients with psoriasis, and it's a first-line therapy for patients with psoriatic arthritis with or without methotrexate. Yet, because of the way we have tested it in Crohn's disease, patients who have failed conventional or biologic therapy, it's relegated in the labeling to that patient population that was actually tested in the study. As far as safety is concerned, again, similar to vedolizumab, we do not see a significant safety signal of pneumonia. Indeed, serious infections were no different in the Crohn's disease population than they were in the patients treated with placebo who are on concomitant therapy all of the groups being on concomitant therapy with steroids and/or immunosuppressives along the way. So again, similar to vedolizumab, we can be very happy about the safety profile of ustekinumab. And again, when I'm talking to my patients about this, and let me state right up front, I forgot to mention, you should know I've consulted for Janssen, and so I've been a part of these studies, and so I do have a definite conflict. These are my opinions about the drug, and these are not the marketing decisions. But you do need to consider that I have conflicts having worked with the company that has developed this. In the overall population, there were no deaths and no serious opportunistic infections. There was a single case of active tuberculosis in a patient in an endemic region. It is going to be recommended that patients are tested for tuberculosis. All of the patients in the clinical trial were tested for tuberculosis and were not entered if they had evidence of a subclinical infection. In the psoriasis population, there's an increased risk of non-melanotic skin cancers, realizing also that in psoriasis, many of the patients had been treated with phototherapy that may have also increased that risk. Immunogenicity was also low. Different assays than we've seen. Again, these were not the Prometheus assays, but ustekinumab does not appear to be as immunogenic as some of the other TNF inhibitors, and I can't comment head-to-head as far as immunogenicity is concerned as far as versus vedolizumab. So in inflammatory bowel disease, we've not had a long experience with ustekinumab, but there is growing experience around the world, and by the time of DDW, we're going to see a number of additional studies coming out looking at real-world experience. One of these has already been presented. Bruce Sands evaluated patients who had fistula within the study. This was not a primarily fistula protocol. The only drug that's been studied for fistulizing disease is infliximab. All the other studies have been post hoc analyses or looking at the subgroup of patients who had fistula. We do see some improvement, but we do not have statistics regarding this because this study was not powered to look at fistula. But we see, similar to what we've seen with vedolizumab in Crohn's disease, a proportion, probably 25 to 30% of patients responding. In Canada, they've had the availability of compassionate use ustekinumab for a number of years. And Chris Ma in Canada has assimilated data from several different centers looking at ustekinumab. Now, the dosing was not the same as in the clinical trials that we've led to approval in the United States. Remember, the dosing in the clinical trial was 6 milligrams per kilogram, initially intravenously, followed by 90 milligrams every 8 to 12 weeks. The Canadians used subcutaneous dosing of somewhere between 90 milligrams and sometimes higher if they dose escalated rapidly, but it is not the same dosing that we use. Nevertheless, when you look at remissions in blue and responses in yellow, it does look like, did I have that right? I can't read that small thing. But we see results that are very similar to the results that came out in the clinical trial. But they did something that I think we need to do in our prospective studies. They divided the patients on the left, you've seen, dividing between immunosuppressives naive or immunosuppressive exposed, and here, giving the lower doses, the patients who were on immunosuppressives in a post hoc analysis did better. It may be due to lower doses, we don't know. Again, this is a post hoc analysis. But I also think what's important is they divided the patients according to the Montreal classification of disease behavior. And as I said, we don't expect drugs to treat stricture formation. And indeed, the patients who had stricturing disease did significantly worse than the patients who had only inflammatory or fistulizing disease, again, in this open label experience. We also have some new data that's been evaluated from the Unity trials, similar to what Brian said, going back and looking at the patient-reported outcomes. Here with Ustekinumab, you can see differences in soft or liquid bowel movements from baseline in the TNF refractory population within the first 7 days. So we are seeing a signal, at least according to patients' responses. Abdominal pain improved within the first days and week of therapy with Ustekinumab after the IV intravenous infusions in the refractory population. And the Ustekinumab concentrations did stay stable. Let's see. CRP normalized. And as far as endoscopy is concerned, we did see evidence of endoscopic healing, but it takes a longer time. We noticed this with anti-TNF therapy, and again, by the end of the year, only about 25 to 35% of patients had an endoscopic response. It may be very difficult to heal these ulcers in Crohn's disease, particularly the deep ulcers that have been around for a long time. So I just want to conclude that inhibition of IL12 and IL23 has demonstrated benefits in a number of immune-mediated diseases, including psoriasis, psoriatic arthritis, and now in Crohn's disease. You should know that trials are underway in ulcerative colitis. Theoretically, the pathway should be similar, and indeed there are phase 3 trials now of interleukin-23 inhibitors in both Crohn's disease and in ulcerative colitis that are evolving. And we need to keep in mind that consistent with other agents, dosing in IBD is considerably higher than for other immune-mediated inflammatory diseases. Thank you.